Well, welcome to the finals of the 2025 edition of the Outstanding Research on Development Awards, which is a category, an award category under the Global Development Awards competition. I'll just say a few words about this program of GDN, and then we'll move on actually to the finals. So today we'll have actually finalists who have gone through a very long selection process who will pitch the project to a jury. And I'm here with the jury members, and I'll introduce them in a second. And the jury will then meet separately after the session to deliberate on the awards. So just a few words about the Global Development Awards competition. It's a scheme that is actually run by the Global Development Network, so it's our program, but it's funded, generously funded by the government of Japan, the Ministry of Finance in particular, for a very long time actually. So we started in 2000, and through the PHRD fund at the World Bank. It happens to be GDN's largest and longest running program. We distributed around $4 million US dollars to research projects and implementation projects, development projects. And this is something unique about this program. We have both grants for research projects and for implementation projects. And through the years, we've been trying to bring them closer together and creating incentives for them to interact across research and implementation. The projects, of course, today we are having the finals of the research component of the competition, and tomorrow we'll have the finals of the implementation component. We will be funding projects that will last 12 months. Of course, the program is targeted at researchers in low and middle income countries exclusively. We have 3 finalists and 3 prizes. The jury can decide whether to give all 3 prizes or not. But the first prize is 30,000 USD. The second will be 20, and the third prize will be 10. And the winners will actually have a chance to receive a top-up grant at the end of a project to actually work, a top-up grant of 20K, to work closely with the implementation awardees of the same edition. So trying to create bridges between the research awards and the implementation awards. As many GDN programs, actually as all GDN programs, our work is not that of just passing on money. Right? This is really not what we do, also because we're not a self-endowed donor, so we're actually spending somebody else's money, typically, right? So in this case, the government of Japan's kind of contribution. This means that we really see our job in terms of all the support that goes towards the projects that goes beyond money. We organize trainings, we pair grantees with mentors for the duration of the project. We have a number of activities throughout the 12 months of implementation, support communication, dissemination, etc. The 3 finalists you'll hear today have gone through a pretty structured and systematic selection process. So this year we had, 41 applications from 18 different countries. Half of the applications were actually laid by PIs who were female. And they all went through, number of steps, the selection process from eligibility, which is done in-house, to 2 stages of review. One led by younger mid-career researchers, again, from low and middle income countries. A second level review by senior researchers. And then we have, of course, the jury meeting today, which is a 4th layer of selection. Every year, this competition changes topic. Since this is funded by the government of Japan, we are keen to align the topic of this competition to the ODA priorities of the government of Japan, which we like anyways. So it's not a big constraint for us. And this year, the topic is digital transformation for universal health coverage. Japan has been at the forefront of universal health coverage throughout the years. Let me present the jury very, very quickly. So the chair of the jury is Professor Yoichi, who is the executive director of the JICA Ogata Sadako Research Institute for Peace and Development in Tokyo, who's joining us actually from Japan. So thank you, Professor Mina, for connecting quite late for you in the day. And we have Jean-Louis Arcand, who's the president of GDN. We have Kiran Raj Pandey, who's the executive director of Health AI for All Networks, HAINet. And we have Joanna Schumer Nkolo. You've heard her speak in the previous plenary, and she's part of the jury today as well. The jury will assess the presentation based on these 6 criteria. The contribution the research aims to make to the theme of this edition, the innovativeness or the quality of the methodology, the scientific quality of the project overall, the clarity of the policy implications of the project. Of course, when there's a feasibility of the project in terms of the composition of the team and the cost effectiveness, so the structure of the budget, and finally, the quality of the presentation that you will see today. We have 3 finalists for the ORD category. So we have Anthonio Oladimeji, who's from Nigeria, and is going to talk about nutrition. We have Asogwa Chisom, who's also from Nigeria, from, of course, different university, who's going to talk about stroke prediction and prevention. And we have Nissily Mushani, who's from Malawi, and we'll be talking about antenatal care. There's much more to be discovered about this competition. The over 100 grantees that we have in this program, we have been accumulating in this program over the years. But now I'd like to give the floor to Professor Mina to just say a few words before we get started with the presentations. Professor Mina?
Yes. Do you hear me?
Yes, loud and clear.
Okay.
Floor is yours.
Thank you, Francesco. So let me give just 5 or 4 minutes to greet you. I'm Yoichi. I'm Executive Director of JICA Ogata Sadako Institute, Research Institute for Peace and Development. So it is a great honor for me to participate in this competition as chair of the jury. So now let me begin by expressing my deep gratitude to the organizers of the Global Development Awards competition. GDN has always been at the forefront of global development trends. And the theme for this year, digital transformation for universal health coverage, is both timely and immensely important. So in recent years, we have witnessed a remarkable progress in the field of digital health. So ICT and AI technologies are being widely applied from clinical settings to policy making, contributing significantly to treatment, prevention, and health promotion. So even in developing countries, the adoption and the utilization of digital tools are advancing in a remarkable pace, raising expectations for the realization of universal health coverage, UHC. So however, to ensure that everyone can benefit from these technologies, it is crucial to adopt human security perspectives. It's also the national, is a priority of Japanese ODA. So human security is a principle that aims to build a society where people can live in dignity, free from threats to their lives and livelihoods. The importance of human security in the digital age is actively discussed at the international level. Special report of UNDP published in 2022 highlighted how digital technologies can expand human capabilities and enhance human security, and also pointed out their potential risks to humanity. In response, the report of the UN Secretary General on Human Security, released in 2024, emphasized the need to adopt a human-centered approach to mitigate these risks and maximize the benefits of digital innovation. So this perspective is also reflected in the Global Digital Compact adopted in 2024 in New York, which emphasized the principle of leave no one behind. So it is essential to ensure that technology is designed, used, and regulated in ways that uphold the human dignity. So the collecting empirical data, evidence, and nurturing the actionable research, actionable knowledge are essential, indispensable for driving more innovative and effective initiatives for human-centered health security. So supporting research projects led by promising young scholars like all of you is crucial to this effort. I sincerely hope your research will further expand the potential of human-centered digital health and contribute meaningfully to the realization of UHC. So, for many years, the Japanese Award for Outstanding Research on Development has played a vital role in promoting high-quality research on development issues. Many past recipients have made significant contributions to GDN's mission, effectively utilizing the award and GDN's mentorship. So I'm proud of these achievements. So finally, on behalf of the government of Japan, I'd like to thank all applicants and the finalists. I also extend my deepest appreciation to the members of the jury for your dedication and hard work. So now let's begin the final round of the competition. Thank you. Thank you very much.
Thank you very much, Professor Mina. Let's move indeed to the final rounds. The way this will work is that we have 15 minutes. Each finalist will have 15 minutes to present the project. So they'll come on stage and present the project, and we'll have each one of them has a PowerPoint presentation to accompany through the explanation, and we'll have 10 minutes of questions. We'll give priority to the questions from the jury, and if we have time, we'll open it also to the audience. So, and I invite the jury, you decide whether to stay on stage or whether it's easier to see the slides from the first row. It's it's up to you. So I'd like to call on stage our first finalist, Anthonio Oladimeji. Welcome. Who will present the project Advancing Women's Nutritional Health Equity in Nigeria. So the floor is yours. You have 15 minutes. Thank you very much. Good luck.
Hello, everyone. My name is Anthonio from University of Ibadan, and I'm here to talk to you today about advancing women's nutritional health equity in Nigeria, development of an AI-powered gendered social burden interest. To start the story, I would like to introduce you to two Nigerian women who revealed a critical gap in how we measure health burden. I want you to meet Fatima and Amina. Amina is known to have moderate anemia, and she lives in Lagos. She finished her secondary school, and she also makes her own healthcare decision. But also meet Fatima, who lives in rural Kano. She never attended school, and her husband only decides when she gets healthcare decision. And she also experienced regular violence. This is a question to me and you. Do both women experience the same health burden? I guess we'll find out in the next slide. Current health metrics say yes, but reality says no. Daily, known as Disability Adjusted Life Years, created by WHO and a pool of international experts, gives a moderate score of 0.05 for both Amina and Fatima. It assumes that Amina in Lagos and Fatima in Kaduna has the same score. But this is a blind spot that policies created by the Nigerian government for the past few years have always missed women who need the utmost, when they need it, how they need it, and why they need it. But this is what keeps me up at night. This problem of Fatima is not a unique problem. It is a problem of 29 million Nigerian women who suffer invisibly today. Why? Because these current metrics cannot distinguish between their burden. When violence, powerlessness, poverty is shown to amplify malnutrition, then what do we do? Also, the National Policy Officer from the Federal Ministry of Health mentioned that the current National Strategic Plan of Action for Nutrition in the country and also the National Gender Policy both lacks integrated gender-sensitive data. What does that mean? For the past few years, policy created by the Nigerian government have actually missed women like Fatima for solutions they need. So what exactly is the solution we've created to solve this problem? I introduce you all to the Gender Social Health Burden Index. This solution contains of 3 phases. 1, it combines the nutrition problem of Fatima and our social lived realities, our violence that she faced, our powerlessness. Next, a weight is created from Nigerians' own women experience, not a pool of international experts' confidence. Lastly, we identify where the burden is heaviest, not just where the number is highest. But what truly makes GSBI innovative? It is in 4 core main, and let me introduce it to you. 1, context-specific weights that AI and machine learning can learn from 83,000 plus Nigerian women themselves, their story, their data that we already have. Next, social factor embedded in calculating these scores. Lastly, we talk of causal inference. Most studies will do correlation, tell you what factor causes health burden for Fatima. But this time, we want to see how much violence, how much malnutrition, how much the powerlessness of Fatima has compounded our health problem. And lastly, precision targeting. The National Institute for Socioeconomic Research acknowledges that such tool will help push the nation for their next nutrition policy agenda. But what is the real question to this research? For me and you, the main question should be, how can context-specific AI measurements identify high burden that dailies created over 30 years ago still being used today misses? And how does it help the Nigerian government to target nutrition resources efficiently? We have 3 main sub-questions to answer that. 1, development. How can artificial intelligence and machine learning be used to develop a social burden index to show the solutions for these Nigerian women? Second, analysis and causal inference. We are going to be using multiple machine learning methods. Just consider them as doctors who will give you clinical symptoms on how your problems are. Will this help us? Next is policy application. We create AI tools, we create machine learning tools. How can the mere person, front-end users, make use of it? How can policy stakeholders like me and you understand what this solution will profile for us? How do we do that? Through 5 core objectives. 1, we integrate the nutrition story of Amina and Fatima, as well as our social realities every day. Also, we'll be able to identify vulnerable population across different geographic zones and socioeconomic group in the country. Thirdly, cultural analysis, which I'll explain better further. 4th, how do we make sure that this tool goes in line with the Nigerian 2021 to 2026 policy framework on nutrition? And lastly, when you build an AI tool, what you want to check is for mitigation. Is the accuracy real? Is the precision real? Does it truly show what we are doing is actually right? And the Federal Ministry of Women Affairs and Social Development agrees that such tool is very important to make sure that the GSBI goes very, very well. How do we do this? We have been on what Nigeria already has, not collecting new data. Like I said, we have the story of over 3,000 Nigerian women. Their demographic health survey, in terms of their nutrition status, minimum dietary diversity of women in Nigeria across 10 food groups, their menial level, their body mass index, and more to go. Lastly is their social indicators. Does Fatima get to go to the clinic at her own choice, or her husband gets to tell her when she go to it? Or give Fatima anemia decision or clinical symptoms solution. Does she say no because her husband is not allowed to do it? So what are we going to do at the end of the day? We are measuring how much combining nutrition, health, and social determinants matters to give us a true burden score for her. What we are trying to find out is a 0.5 for Fatima is not exactly a 0.5 for Amina. They are 2 different reality stories. How do we do that? Our research design is going to adopt a cross-sectional research design in 4 phases. 1, data preprocessing. We are combining 2 large data sets that needs to be harmonized into one. By using multiple formats like multiple imputation, we can remove errors, inconsistencies in these data sets to reduce noise and overfitting when we are doing our machine learning model prediction. 2, feature selection. This combined data set has over 200 variables, but our goal is to pick the most significant ones to give real solution for Fatima to solve this problem. 3 is predictive modeling. It's like you are going to see 3 doctors for your clinical symptoms instead of seeing 1. You feel more confident, right? Because 3 clinicians can tell you what your problem is because they've looked at it. That's how predictive modeling works. We use machine learning algorithm like neural network, random forest, a sample method to look at how these variables and predictions are coming out. Do they give the same answer? Does it matter? And lastly, causal inference, not correlation. Like I said, if you go through correlation, the question we'll ask is, how does violence compound Fatima's problem? But for causal inference, the question we're asking is, of 0.05 for Fatima's problem, how much or how many percentage is violence taken out of it? For the 0.05 for Fatima's health burden, how much percentage does our inability to make money compound to that score? Is it 30% of it? This is very important for policymakers. Why? Because now they can give specific solution and intervention for Fatima because they know that our problem is not only anemia focused. It is focused with the fact that she cannot make her own money. She is not educated. Also with the fact that she cannot go and seek healthcare decision without her partner's consent. Lastly, this comes in 3 other interactions to make sure this is real. 1, a first order effect. How does a specific value, say our education, affect our healthcare body or our health outcome body? Next is, how do we take for factors 2 or more that compounds it? And lastly, how do we also take for intentionality among other variables? But when we develop such tool, how do we validate that it is real? It comes in 4 tracks. 1, internal validation. Can these selected model predictions be trusted by you and me? We are going to cross-validate across various states in Nigeria as well as geographical zones. Second is external validation. Does the GSBI tool truly reflect the burden of core Nigerian women like Fatima, which will be done through combining GSBI scores and placing it against existing database in the country? Thirdly, like I've said, we are not saying that dailies is wrong because WHO still uses it till today, but our goal is to complement it. Does the GSBI make it better? Is GSBI better in predicting health outcome than daily? And lastly, qualitative validation. Does this tool make sense to frontline users? When policymakers see this tool, what does it tell them? When expert people like you and me sitting down review the methodology to develop this tool today, does it make sense and does it provide a solution to the singlest Nigerian women? What are the expected findings for this research? First, scientific contribution. We are going to be developing the first validated context-specific health body measure for Nigerian women like Fatima, like Amina, and millions of other women. 2, a framework for other countries to work on. It's very simple. We give you a machine learning algorithm, you plug in your own data, and you get your answer. Simple. In terms of global significance, this will serve as a template for global South countries on how they can use AI to build their own measurement tool. We don't have to focus on Western standards all the time. And lastly, in terms of policy implication for the Nigerian government, we believe that the 2 policies currently used in the country will close in the next 1 and 2 years. This serves as an open window for the Federal Ministry of Health to allocate funding based on true burden, not on population density. Secondly, states that have amplified vulnerability get to receive prioritize more support. What does that mean? Fatima gets clinical help as well as social help from different experts at the same time. Why Amina only gets clinical help? Because she understands the importance of being sick with anemia. Lastly, we're able to identify programs of women who need integrated support as of standard care, and also we're able to track gain indicator of such disparities among women. So let me go back to the bottom line of Amina and Fatima, like I've always said. Current system will allocate the same resources to both women in Nigeria. But ours is telling that our approach recognizes that Fatima needs what? More intensive, multifaceted support. What is our vision for this research? An health system that sees, are the response to women's realities, not just their clinical symptoms. Remember, 2 women made us see this gap. Now, 29 million women are waiting for us to close the gap. And today, we have the power to change that story. I want you to meet this is our project timeline. I also want you to meet the beautiful team behind this research. Thank you.
Great. Yeah? You switched off the, the conference center. No, don't worry about it. Great. Thanks very much, Antonio. Now let's go to the jury. Feel free to come back on stage if you like, or I can come to you with a mic. Who wants to start? Yeah. Yeah. Who wants to start? Anyone?
Is this working? Antonio, well presented.
Thank you.
Second, it's an important question you raise. How do you measure disease burden in an accurate fashion? It has a huge amount of policy implication. You point out a very important, you touch a very important policy nerve there. And if we could do this work right, it could have a huge amount of implication, not just in Nigeria, but elsewhere too.
Thank you.
The third thing you point out about DALIs in being imperfect measures. All measures are probably imperfect. We can agree on that. And DALIs are no exception. There's been quite a bit of criticism. So as a result, we have what we call quality measures, which are a derivative of the DALI measures. It's also right that some experts sit at a table somewhere and then decide how much of a burden should a disease be ascribed to. And that is probably not the best way to do it. And your attempt to try and get the women who actually suffer from the disease to contribute to that piece of work, that is commendable as well. But again, that touches upon quality measures, which draw upon the same principles. Having said that, the one thing that I'm a little not sure about, and I'm not sure if you've thought about, or if your research team has thought about, is you seem to be conflating between the idea of an outcome measure of health burden, and the determinants of that particular health burden. And what you seem to be proposing here seems to be a conflation of the two. So yes, it is true that if women have extenuating situations that result in bad health outcomes, we should be aware of that, cognizant of that, and we should have policy interventions to mitigate that. But I'm not convinced that the way to do that is to sort of club that particular risk factor along with the outcome measure that we are interested in. So when we are interested in measuring anemia, we really want to measure anemia and not just club together risk factors that could potentially lead to anemia. You see what I'm trying to say?
Yes.
So what you seem to be proposing here is that we say that certain patient has a greater burden of anemia because he has other extenuating risk factors like a social situation that may not be conducive to healthy living. I'm not exactly sold that that is a good way to approach this problem. We should dedicate more resources there. We should find out a better measure of vulnerability there. But taking those measures and then clubbing it with an outcome measure that those predictors might probably lead toward, I don't think that's the right way to do it. It causes lots of problems with identification, but it results in a faulty measure of a certain problem. And that, again, can unleash a whole lot of other problems. So I think there's something to think about there. I'll stop there, and if there's that time, I can.
Thank you very much. We have 10 minutes. There's also Professor Mina, of course, online. So please let us know when you want to come in. But does anyone? Yeah, Joanna?
Thank you. Thank you very much for the great presentation, Antonio. I'll be quick. So I have 3 main questions. My first question is related to the use of AI in this context. So can you tell us a bit more about what's the value out of using AI compared to using traditional statistical and econometric methods? Are we sure that we need to use AI for the specific use case? My second question is related to how you're going to, what's the plan for the use of the index? Is it to target at the local level? Because like you're going to be using data from the based on the 2006 census. And I assume that the enumeration areas have changed over time, especially around secondary cities. So is that going to have an impact on the interpretation of the index? And my final question is related to your team and the implementation of the project. Obviously, with your team, you have a lot of experience. You've won many projects related to AI. And is there anything you learned when implementing those research projects that you can implement and use in this project?
Thank you, Ma.
Thank you. We'd like to start answering these questions and then...
Yes, yes.
So just a reminder that there's translation going on. So we need to be mindful of speed when we talk, because otherwise translators will...
Yes, okay, thank you so much. So thank you, sir, for that question. And this is what the team has actually considered so far. We actually went to read about ALIs to see how it so much differs from dailies. And in all sincerity, like you mentioned, there's still a lot of loopholes in how it much differs. But the reason why we considered GSBI as a tool is because we've talked with policy officers in the federal government sector. National Bureau of Statistics even had a roundtable to ask them, how has these two tools effectively saved the typical Nigerian women? So we sat down and drafted out this limitation. We were like, okay, let us consider making our own tool, and let us be real. This pilot will give us a probable answer to this question. So the best way we could sit down as a team to coin out a solution for this problem is first, to create any AI ML model, one, and also to create a story that has a very clear answer. We need data. The most available resource data in the country is the 2018 NDHS. Luckily for us, 2 days ago, the NDHS released the 2024 data set. But when we were building our AI ML pipeline, we believed that in the future that much data sets will be released. So we created a sort of pipeline that we can always impute more data the way it comes to give us more health burden score. That's one, sir. Two is also this NDHS and the MIC data has a lot of variables. So the best we could take over the team was to break this data set into 10 folds and make sure that we use different algorithms to look for the most impactful variables that confound this women health burden across these 10 folds and select them. This helps us remove the problem of multiple issues because we believe that this is data. We don't know if it was accurately collected. We are trying to remove overfitting so that it can really show the reality of a real Nigerian women, not just computerization numbers. That was the answer we could give at that time. But now that you've mentioned it, we also look at it in the limitations of our study to impute it more to get better answers. Thank you. Dr. Nkolo, if I'm right, thank you. So the last question, I will start with that first. So as a Wellcome Trust grantee, I've had a lot of series with them on how to use AI for low resource environments. And in all sincerity, it's just the truth. Sometimes develop a machine learning model and it tell you it is 95% accurate. But in all sincerity, that 5% that is not there is the real story of that person are trying to solve their problem. That's why for building this solution, every step of the way, from data preprocessing to data validation to model prediction, there will be a noted down review methodology of the AI and machine learning process we are using, whereby experts will sit down to compare whether you are a computer scientist or an expert in the health sector. Does this go in line with the real world story of a typical Nigerian women? I think I forgot some of your questions.
I think, yeah, we have 2 minutes left.
Yes.
So I don't know if Jean-Louis have a question. Or yeah, let's go through to Rosamina first. If you're, we can't see on the screen for some reason. Rajesh, can we have Dr. Mina on the screen?
May I ask a quick question?
Yes, please. Please go ahead.
Actually, I'm not very sure how you calculate mortality from DHS and MICS, which do not contain mortality data. So you use AI.
1 second, because the volume was too low. Can you go again? How do we calculate mortality from?
Mortality using DHS and MICS, which do not contain the mortality data.
Yes, thank you so much for that. For the mortality data we are currently using to explore currently comes from the NDHS data from the pool of and the International Institute for Health Metrics, which we've reached out to give us a pipeline on how they usually calculate their mortality data for the typical Nigerian environment and low resource setting around Africa. So basically our goal is to do it and compare it with our own pipeline. As at now, we are working with biostatisticians in the University College Hospital in Nigeria to give us a real model on how we can use the NDHS and MICS data to calculate our own mortality and compare it to one that's already been used since. If it truly works, we'll add it into our pipeline for our solution.
Okay. Jean-Louis, you want 30 seconds and 30 seconds to answer?
Yeah, I just wanted to understand how then this actually works, because you take the DHS data and the mixed data, you estimate your model, so you get some kind of model, and then what? I mean, then a woman goes in, and then you have all of these variables to calculate the index.
Yeah, okay, so I'll make it very, thank you. So I'll make it very.
It's the implementation that I want.
Yeah, the implementation. So let's assume my health burden score because of anemia is 0.05. But because of machine learning and artificial intelligence, it is showing me that out of 0.05, violence takes 0.19. It will show me that not being educated, or because I have a primary education level, it is 0.14. So this combined score will be showing, okay, what was the real value? So if I truly had a level of education, that means I'm going to have a discrete score of 0.19 in my health burden score.
But how are you sure then that they're telling you the truth?
So that's one of the things we've actually looked to by collecting the data set, because the goal is that this, like I said, we are consulting like 3 different doctors instead of 1. This is where this machine learning prediction and expert comes in to look at why we are doing this work. It's not just a AI work. It's a human in the loop process.
Talk about the implementation. I mean, what if the woman tells you that she's suffering domestic violence, but she actually isn't? So then she's going to get nutritional supplement, and then the one who doesn't lie is not going to get the nutritional supplement. How do you deal with that?
What I can say right now is the data we have is a story of this woman that has been collected in the past few years, and that's what we are working on. I would prefer to the Federal Ministry of Health, which already have a roundtable with. Even though this solution will be preferred based on the results we have, we also believe that with the policy recommendations that we are giving, they should not just forget every other one, because that was what the story is telling. They can still make it multifaceted for everyone who needs it, so no one gets left out.
Thank you. And I'm afraid we need to move on to the next presentation. Thank you very much, Antonio, and good luck. Yeah. Okay. Our second finalist is Asogwa Chisom, and because of unfortunate visa issues, she couldn't join us today, but she's online, and she'll give us a presentation through Zoom. Project is titled Advancing Interpretable Machine Learning for Stroke Prevention, Prediction and Prevention. Chisom, the floor is yours. Can you hear us?
Hello. Good day, everyone.
Your 15 minutes. Floor is yours.
Hello, good day, everyone.
We can hear you loud and clear. Feel free to share your screen and start the presentation. Thank you.
Okay, please, can you see my screen?
Yes, you may go ahead.
Okay. Good day, everyone. Thanks for having me here. I'm Asogwa Chisom Nneoma, a PhD student at the University of Nigeria, Nsukka. I'm presenting a proposal on advancing interpretable machine learning for stroke prediction and prevention. The AI accuracy for stroke prediction from studies has been established to be well over 92%, but some of this model lack transparency for adoption in clinical practice. Therefore, we are proposing a model that explains AI results and enables healthcare workers make precise, confident, and timely decisions. From here, we can see Grace, who is a community healthcare worker in rural Enugu, and Mr. Ade, who is a farmer. He has hypertension from vital measurements being taken by Grace. She knows that he's at risk of stroke, but she doesn't have the specialized knowledge, and she doesn't have access to the tools to treat Mr. Ade. So she can only give basic advice such as reduce your salt intake and come back in 6 months for further checkup. But from research, we can tell that within 6 months, Mr. Ade is likely to have a stroke occurrence. We have two problems. The first problem is global stroke, this global stroke challenge, and we also have a hidden problem which we refer to as the AI paradox. So globally, stroke is the second leading cause of death, affecting over 15 million people, and 11 to 12% of those people die as a result of this stroke. However, Nigeria, from studies, seems to suffer 2 to 3 times more than the global average of stroke. This organization suggests that over 80% of stroke-induced mortality and morbidity will impact low to medium income countries such as Nigeria by 2030. This is possible because in Nigeria, there are only 5 dedicated stroke units. So for patients like Mr. Ade, who live in Maiduguri, they have to travel, or he has to travel at least 18 hours or more to get to a stroke unit. This reduces his chances of surviving the stroke crisis, because from studies, if under a stroke crisis, one should get to a stroke unit at least 4.5 hours within the stroke occurrence. Research has also shown that at least 89% of these individuals don't arrive the clinic on time, therefore leading to late diagnosis, most likely disability, or even as serious as death. Most of these units are also overloaded. According to World Health Organization again, at least 200,000 to 300,000 individuals should be serviced by just one stroke unit. But in Nigeria, we are having approximately 44 million people being serviced by one specialized stroke unit. From the graph here, we can see that as late as 2008, 1 per 1,000 people die out of stroke. But more recently in 2025, we can see studies saying that 6 to 7 people per 1,000 die as a result of stroke. The hidden problem. AI is accurate from studies or with above 92% accuracy, but it lacks transparency. Yes, we are aware that there are some techniques that have helped to curb this transparency, but I will explain further. Some clinicians don't understand the explanations of these stroke predictions. Therefore, they have failed to adopt the techniques as much as they are in existence. This has led me to ask the question, how can we advance universal health coverage by deploying AI-powered systems to prevent stroke crisis in countries like Nigeria, where lack of trust in technology and scarce infrastructure are the key barriers? The key goal here is to build a trustworthy and transparent AI tool for stroke risk assessments that clinicians can trust and understand at the same time. We have to do this by bypassing these problems. Firstly is the interpretability issue, which I already mentioned, the generalization problem, because some of these advanced tools are being designed for high-income countries, Western countries, but we don't get them here in low to medium-income countries. Even where they exist, they fail to be adopted. We also have the problem of infrastructure. So we lack the human capacity. We also lack the advanced equipment to help those suffering risk of stroke here in Nigeria. We propose a solution which combines enhanced accumulated local effects and kernel sharp. These are two interpretability techniques which will be combined to form a hybrid model that can help to explain AI model results better than existing techniques. The key enhancements to our ALE, firstly, is that we are adopting what we refer to as adaptive quantile-based binning, instead of fixed base binning, which exists in the traditional ALE method. We'll also be using smoothing methods to suppress noise, which comes from healthcare data sets on this side of the world. We'll also be applying bootstrapped confidence intervals as a measure of certainty. So what the SHARP technique helps us do is that for patients like Mr. Ade, it can accurately say that this is the reason, or these are the reasons, or these are the factors that have led Mr. Ade to having a high stroke risk. Then this is the traditional ALE, and this is how it works. So we have employed the use of sample data sets to plot this graph. We have done this to show that when we get the real data sets from Nigeria, our model will also work. So from here, we can see the stroke risk increasing with increase in blood pressure. From literature, it's established that stroke risk increases as blood pressure increases. But from this graph, we can see that traditional ALE tells us that at 120, a patient is at low risk of stroke. It's a lie. But also at 180, the graph falls. This is a very big lie, meaning that a traditional ALE is misleading and also deadly since we are working on health. This is our enhanced ALE plot. We can see a smoother plot, an easier to read plot, and we also have the confidence intervals telling us that for patients like Mr. Ade, blood pressure, an increase in blood pressure does not increase his risk for stroke, but this is also a pattern that is general among other populations. So our stroke model will be trained and deployed as a web tool. So here the clinician imputes patient records such as age, cholesterol level, blood pressure, and other features. So this data will be run through a prediction model. This is all done in the back end because this will be deployed as an offline capable web tool. The prediction model predicts the risk score for the patient. Then this score is run through the explanation engine for the SHARP technique and the ALE technique to give us more insights on why that specific patient has the stroke risk score, and also ALE helps to validate this information by giving us evidence of those top factors against other populations. So the end result here will be a report showing patient risk score, the critical factors, the ALE evidence, and recommended prevention strategies, individualistic recommended prevention strategies. So we are moving from an era where we have people traveling long distances and queuing for long hours waiting for specialists to a time where we can hand the right tool to the right people to make the right decision, hence saving lives. The proposed methodology is in 3 phases. The first phase is the model development and validation. We will be engaging with stakeholders such as representatives from local communities, healthcare workers, Federal Ministry of Health, State Ministry of Health, to understand their insights on how this tool can be developed and the kind of data that we need to work with. We'll also collect secondary data sets existing online, which will further be validated with Nigeria data set. Our model will be trained using random forest. We'll also develop our hybrid model. All these models will be validated using metrics that we have set in place. Now the phase 2 has to do with the mixed methods to development and field testing. So here the tool will be deployed in 5 clinics in the nation. And from here, we'll also collect quantitative and qualitative data from the users of this tool to understand how many times the tool is used, how it works, just basic usage metrics, and also human assessment metrics to understand how the tool has helped them to make confident decisions. All this data will be integrated and analyzed using what we call joint display analysis. Thirdly, we'll do an impact evaluation, holding a second stakeholders meeting to help us put together a policy brief for integration of these two into the different national health programs. Now, these are our deliverables. The outputs, we have the hybrid framework. We have our offline capable web tool. We also have policy briefs and implementation protocols. We also have documented guides for training the healthcare workers. The outcome of this is early prediction of stroke, a significant increase in trust, confidence, faster stroke assessments in primary health centers, reduction in unnecessary referrals to specialists. The impact is reduced stroke mortality and disability. Nationally, economic savings of approximately $800 million in prevented costs, strengthened health system, and a global scalability of this tool to other low to medium income countries. Now, the policy implication is that our policy aligns with Nigeria's national health policy and SDG3. It integrates, our tool integrates with the National Digital Health Initiative. We have the potential to save at least $800 million annually by preventing stroke deaths and disabilities. These two will be piloted in 5 states with plans for national upscaling. Our competitive advantage. So here we're moving from AI in the research labs to AI in rural clinics. So for the common man who has no access to digital health, these are offline capable tools will present the opportunity for access to digital health through community health care workers. Therefore, empowering, this way will be empowering the primary health centers to be frontline defense for stroke prevention. This is socially impactful as well because we will be preventing families from being pushed into poverty. This is technically innovative because to the best of my knowledge and from my research, this is the first AI hybrid interpretable tool that has been developed for low to medium income countries to enable clinicians make trustworthy decisions, clear decisions for stroke prediction. Our team is comprised of individuals from different disciplines, AI experts and economists, a statistician and a medical practitioner. The project will span
1 minute
across 12 months. Okay, so the vision of our work is to transform the 5 stroke units we have now into 5,000 AI-assisted clinics tomorrow, and to empower these frontline health workers with tools that can help them make decisions and save lives. Now we will be changing the narrative from stroke treatment to stroke prevention. So our technology works, the need is proven, the impact is proven. We only need your decision to make it happen. So the funding from DGN will help us to drive home the impact of our work to the common man in Nigeria. Thank you.
Thank you very much. Okay, let's move to questions. Who would like to start? Ajay, you had less time earlier. Please go ahead now.
Thank you for that presentation. I have a very simple question. You used this term accuracy, and you said that the AI prediction, this is the big problem with all AI diagnostic tools, at least my friends who work with this tell me this. But what I actually want to know is, I want you to be a lot more precise. I want you to tell me what the type 1 error is and what the type 2 error is, because you have to distinguish between the two. In statistics, we talk of type 1 and type 2 error. So 92% accuracy tells me nothing.
Okay. I said it's been established that AI tools have an accuracy of above 92%.
Yeah, but you're talking about type
some
1 or
AI
type 2 error? That type 1 or type 2 error? That's a classic, that's a standard statement in statistics. That's what I want to know.
Okay, I'm not a statistician, but we have a statistician that we are working with. He is on ground and maybe he can answer that question.
Okay, just so that you understand, it's because you have the first possibility is that the AI tool diagnoses someone and therefore then they get treatment and actually they don't have that problem. Okay, they're not at risk for stroke. And then the other type of error is you miss someone who is at risk for stroke. Those are two completely different types of statistical error, and the word accuracy doesn't tell a health professional what we're dealing with. That was just it's an important point in terms of your presentation. All right, next person.
Yes, next. Who wants to go next? Rosamina? No? Yes?
Just
yes,
one
please.
simple, thank you, simple question. How do you secure collaboration from 5 major Nigerian hospitals? How do you secure collaboration? Because medical practitioners are quite busy people, so, and your description was not so precise.
Okay. As I mentioned, we have a medical practitioner that we are working with, but of course we are going to reach out to different stakeholders, just as I mentioned, to different federal ministries of health, state ministries of health. Of course, this is something that would take time. But because it's important, we would definitely reach out to clinicians, health workers, different hospitals to get their input even before the work is started.
Okay. Kiran or
Sure.
Anna?
So let me take off. Do you want to go? Take off from what John Lewis just said. The first thing you mentioned that the algorithms that are out there are already very accurate. I don't think that is true at all. The reason I say that is with stroke, you can actually do 2 things using AI. One is actually diagnose stroke. Other is predict risk. And within your presentation, and I went through your application as well, it was not clear to me that you fully understood the difference between the two, especially if you're looking at predicting the future risk of stroke, which is what you're proposing to do here, I think. 92% accuracy is not good enough at all. You didn't specifically mention as John said, what the sensitivity or the recall and what the precision was with that. But even if it was 99% specific, if you're taking this at a population scale, you would generate a lot of false positives, and that would not be good enough for clinical production. That's number one. So I think you need to really reconsider your assumptions there. Validation, how are you validating this? I didn't see any foolproof plan for validation. You could refer to cardiovascular risk scores that have been developed. Those risk scores take about 15 years worth of research. A lot of that is validation because you have to measure a certain risk score and then you tally that up with a health outcome. I don't see how you would do a similar validation here or how that has been done elsewhere. I'm not exactly sure. And even if you come up with a risk score, at least the information that you gave us, I'm not exactly sure if it's very clinically significant. I don't think it's changing a lot of clinical decision-making for the nurses or the health workers. So I want you to re-examine those assumptions you made as well. And I'll stop there.
Okay. Joanna, did you want to ask anything specific or also a comment is fine? Huh? Yeah. Joanna.
I just have a one quick question. Thank you for the great presentation, Chisom. Coming back to the data you're going to get from the hospital. So what is the size and the quality of the data set that you will use? And how will you ensure that the model is robust given that potentially the data will be noisy or of limited quality?
Chisom, do you want to respond?
Okay, sorry. So we will be using secondary data sets for now, but we are looking at getting local data from at least 500 patients from 5 clinics for a start.
Okay, any follow-up questions? Otherwise, we can open quickly to the floor. Is there any question from the audience? No? Great. Thank you, Chisom. Thank you very much. Let's move then to the third finalist, Nissily Mushani. Please, the stage is yours.
My name is Nissily Mushani. I'm a PhD student at Maseno University in Kenya, but I am from Malawi. Thank you for this opportunity to share with you my proposed research, which is looking at strengthening climate resilience mHealth systems for antenatal care in Nsanje District, Malawi. This is a proposed participatory study to advance universal health coverage, which is the theme for this year's competition. I have, as a woman, experienced firsthand the effect of cyclones that's due to climate change in Malawi, especially in 2023 when Cyclone Freddy hit Malawi. There was so much destruction, especially related to infrastructure. So in that case, these climate-induced disasters are increasingly disrupting maternal health. It's not just in Africa, but in most of the sub-Saharan Africa. Malawi has been experiencing recurring these cyclones in the past 5 years, actually, causing damage to health infrastructure. This has actually, some studies have already shown that, especially with the Cyclone Freddy in 2023, utilization of the ANC services actually dropped. As you can see from the picture, this is a destruction that most of the districts in the southern region of Malawi usually face. Moving from there, apart from the health infrastructure that we have, in as much as it is already weak infrastructure, we have mHealth systems that are working. For instance, I'll give you what we call Chiparaja phone. This is a health center on the phone that people in the rural areas use to actually communicate with health service providers when they cannot reach the facility itself. It is available on most of the mHealth platforms. These are systems that are there, they are working, they've been proven to work. They have actually helped to reduce mortality rates in the country. However, there is a problem that we've seen with the recurring of the cyclones. The existing mHealth systems lack climate resilience features. They don't have offline support. They are not supported with solar powered electricity. So once we have either floods or just the rain season, usually most of these platforms, they go offline. To this case, they contribute to limited service continuity during climate disruptions. So this leads to the question that I currently have as a researcher. To what extent does participatory integration of climate resilience features into the existing mHealth platforms that we have would actually improve antenatal care service continuity and also user adoption during these climate disruptions in Nsanje District in Malawi? So the whole purpose of my study would be, we have the platforms, but these crises keep on recurring. How do we make sure that there's still continuity when we are hit by these calamities? The following are the sub-questions that I have. How does community participation now affect technology adoption, but also sustainability? What are the implementation challenges, but also facilitators to these proposed solutions? And then also, apart from that, what climate resilient features do communities prioritize, or what would they prioritize for these mHealth systems? As you can see, I did a pull out from a newsletter. That's one of the health centers in Nsanje, a health facility. But then I think in 2023, our minister emphasized this: as the climate crisis escalates, we need to build resilient health systems for the communities. But then, being a low-resourced countries, we also are aware that we cannot just rebuild. We cannot just build new facilities. We need to actually retrofit the facilities that we have, the systems that we have. Moving on to the methodology for my study. So this is a participatory, I'm proposing a participatory action research. It's going to be a sequential, qualitative, dominant mixed methods study. We are planning to have this to implement it for 12 months. With the proposed to have 75 participants across 2 health facilities in Nsanje. The 4 key participant groups will be the pregnant women. These are the primary users, or these are the mHealth platform. Community health workers, these are the system operators who have men being involved, because most of the times decisions about health in my country, they're usually done by the men, unfortunately. And then, of course, also the traditional leaders and the health facility staff. So this is a 4-phased design study. The first 3 months, we are planning to have community vulnerability mapping, but also baseline data collection in these communities. What is happening in there when the facilities that we've actually picked to do the study in, how strong are they? How is the mHealth platform working? If they have the Chipara phone or the DHS or ComCare, how does it work? What are the issues that they've been facing over time due to the cyclones that happen? And then the second phase would be where we are co-designing with the communities. So we are planning to actually have human-centered workshops where we talk with the communities to say, look, these are the challenges that have been happening in this community, but then what are the solutions that they think can work and how can they work better? And then the months 7 to 9, we are proposing to have a pilot. This is a real-world testing to see what improvements can we do that's based on the community feedback. And then from there, month 10 to 12, we do the impact assessment of the main pilot that we've had. Did it work? Is it acceptable to the communities, or any other improvements that need to be done? From my map, you can see that's Malawi, was based in Africa, but then the larger map now shows Nsanje. That's the Nsanje district, and you can see the Bru River, that's the Shudi River that actually causes most of the flooding in the country. And then from there, this is the most rural part of Malawi. The infrastructure, of course, when it comes to connectivity, there's some connectivity there, but infrastructure-wise, roads, but also electricity connection is really very poor. So the key innovation that we are proposing in this study, looking at the photo there, we are looking at to have, what if we had a solar-powered sort of kiosk that the communities or the facility can actually use when there's no power. So this will make sure that the platforms that they're using, the Chipara phone in English, the health center on my phone, can still continue working. In this case, what we're looking at, if we have a solar-powered kiosk that the community can use to charge their phones or power banks that they have. But then at the same time, we're looking at also the facility itself where they have, that acts like a call center where these communities they actually call or communicate or text with. We also keep it running during these cyclones. So if both the community but also the health facility, they have these charging kiosks that are run through solar, they'll probably not have, when power goes off, when the electricity that they actually rely on goes off, then probably we'll continue having the health center on the phone. So some of the technical features we're looking at is to make sure that there's offline functionality, but also data synchronization. So even if someone, when they're offline, they send a message, there's a way that the messages are being kept, but once they're online, then the messages comes through. The other part is I've talked about the solar-powered charging systems for equipment sustainability. And then apart from that, we're also looking at multiple channel communication pathways. Of course, there's the call-in that people can do, clients do the call-in, but also there's a part that they can actually do the SMSs. And then apart from that, also looking at the peer networks that are there. The third part is the automated risk alerts, but also integrated with early warning systems. We have early warning systems whereby messages are sent out, but then these are not linked to the healthy platform. So what we are actually envisioning is if a woman was supposed to go to the facility, but then the system looks around and says, okay, tomorrow you are supposed to come in, but tomorrow looks like it's going to rain. Can you come in today? So that in that way, there's that combination of the warnings. This is the envision that we actually have. Just cannot move on my screen. Okay. Probably come here. So this is the proposed climate resilient health system feature with the integration flow. So as you can see, the part that we feel like it is actually missing is the solar charging infrastructure, which is not there. But once this is built in there, you have sunlight captured by the solar panels. People can charge their power banks and community batteries. You have villagers accessing the charging lockers and ports. So in this case, even the facility is running, and then also at the community level, they have their phones that they can get their messages from. So why do we think this is going to work? We are proposing to integrate with the RedCow platform. It has been proven that it works offline, and I think almost over 100 countries are using it. We are building on trusted but also established systems. The Chipata phone has been working in Malawi for over the past 10 years, so people know the system, they already work with it. Excuse me. Community ownership. The participatory action research methodology ensures that from the word go, we are involving the communities in the project. But also apart from that, the strategic timing. The Malawi digital health strategy is coming to its end this year, so probably there's room for revision next year that we might actually get some of the lessons from this activity, informing the decision making. These are the expected outcome, technical deliverables. We have climate resilient feature specifications for mHealth platforms. Policy products I've already mentioned, informing the digital health strategy. Community-based benefits, of course, enhanced antenatal care access during climate emergencies. The plan is, even the cyclones hits, once we have the crisis, we keep the health centers on the phone working. Of course, academic contribution, we have planning to have 1 or 2 peer-reviewed papers that will be published. The success indicators for this research battery project would be community satisfaction with the co-design features. Do they like them? Can it work? But most importantly, service continuity maintenance during the simulated disruptions. Significance, but also impact of the study, regional scaling potential. In the SADC region, almost 15 countries are going through the similar climate crisis like Malawi. So probably other countries can also learn from that. But also apart from that, the universal health coverage, improving access to quality antenatal care, the gender equity part, protecting maternal health during climate disruptions. And this is the project timeline. Like I've already mentioned, 4-phased. So we hope this can be done in 12 months. And these are our next steps: finalizing our research permissions, but also ethical approvals at national level, establishing community partnership, and yes, beginning stakeholder engagement processes. Thank you.
Thank you. Thank you very much, Nissily. Okay, so question time. Who would like to start? Yeah? Joanna?
Yeah.
Oh, Professor Obino, we cannot see you right now, but would you like to come in?
Oh, yeah, my question is, Nissily, thank you. Could you explain a bit more about what kind of services the mHealth provides? Just giving information or more than that? Simple question, but.
Thank you.
Mm-hmm.
Would you like to take more questions, or would you like to answer this one? Yeah? Okay, let's take a few more questions then, and then Nissily would answer them together.
Thank you for the great presentation. I do have a question about the integration of your using an existing platform. So how are you going to manage like the dependencies on the platform developers? And like, have you already secured an agreement with them? Are you going to have technical support from them? And what happens, like, what is going to happen if there is any challenge with modifying something which is a platform which is already developed by a government organization? And my other question relates to the type of climate shocks that you're going to capture and not capture. So I assume you will only be able to capture some weather events, not all of them. And do you have a sense of like the share of weather events that you will miss simply because we don't know when they're going to happen?
More questions, or would you like to start answering? Any more questions? Yeah, please, Kiran.
Should I go? Okay.
Yes.
Nissily, good presentation. I have a simple, straightforward question. You mentioned resilient health systems, and I guess that would be the end goal for having a resilient mHealth system. I wonder if you've taken a look at what percentage or to what extent is a resilient mHealth platform important to have a resilient health system. You understand the distinction I mean? Is it a small part? Is it a big part? If you could shed some light on that.
Jean-Louis, do you have a question right now? Yeah. Would you like to start answering? Yeah.
All right. Thank you for the
Mike.
Thank you for the wonderful question. So beginning with the first question, what does this mHealth actually platforms cover? So I'll state there are quite a number that we are having, I think for now, probably like 4. I'll start with the Chipata Japaphone is the one that is mostly used with most of the districts. It's widely known, almost covering, I think, 3/3 of the districts in Malawi. But this is mostly now, it was started by a non-government organization called Village Reach, but now government adopted it. Now it's a government-run platform. We looked at this, of course, we've talked with the government officials, they said it is possible, but then we kind of felt that because it is widely used and it's much bigger, it might be problematic probably to run with that. So, okay, first of all, the question, what does this cover? So Chipata Japaphone was initially developed for maternal and child health services. So most of the users are women, and so they can call in, they can text, ask if a child is sick, or they're up for their ANC visits, so they can actually use that. So it's mostly used by women for maternal and child health. And then we have a smaller version that is being run by, should be Last Mile in Malawi, in Nsanje district. It's called Maimwana. It is also focusing on maternal health. So this is the one that we've actually been talking with them to say, okay, it's a smaller version, it's a smaller platform covering a few districts. So this, we thought it is a much better platform to actually work with, and that can actually be added to, these features can be added to. So now that moves me to the other question on dependencies on the developers. So yes, we've already started the discussion and the talks, but also because this is health facility based data, we already had to talk with the Minister of Health. How are we going to do about this? Because we're also looking at accessing data for the clients. So yeah, we have to sign MOUs. We've already talked with the government. We are in talks with the Last Mile, but also Village Reach on how this can actually be incorporated into the already existing platforms. So yes, discussions have already started. On the climate change, okay, weather forecasting. As Malawi, we have those platforms whereby once in a while we get messages on the weather forecasting, what is happening, when rains are due, when are we having thunderstorms or floods. So it's typically how we're looking at the system would be the mHealth platform would actually just scan what I'm trying to find the word, the weather forecasting department is saying according to Nsanje district, because, okay, these districts, because they're hotspots for cyclones, so they're really being monitored when it comes to weather forecast. So this information can easily be gotten even through the local radios. So what we are planning to do is before these the mHealth platforms, the call center sends out these messages or text messages, they just do a quick scan of what the weather forecasting radios are saying or the department is saying, and then they actually merge the information that they're sending to the women. On the resilience, is it a big part? Is it a big component? Yes. For Malawi, especially in Sanje, this is, like I've said, it's the most rural region in the country. Infrastructure is very poor. Healthy facilities, like I've shown on the map, you can see they're really far from people. So people really depend on these messages, the contact that they have with community health workers via the phones. So they're really very helpful. We've had women literally saying, oh, they can call and say, my child is sick. They'll ask them, what? Oh, okay, just give us the symptoms over the phone and all that. So the next day, it's either they'll be told you can do ABCD, or the way you're feeling, because this facility is far, we can already refer you to another facility, which is closer, or it is very far from there. So yes, it is a very big component for us. Thank you.
More questions? Julie, yes? Ano? Any question from the audience? I have a question in terms of how much of the budget for your project is going into infrastructure you want to test. Because in the end, we have 3 prices, right? With 3 different amounts. So one question I usually ask everyone, but now I'm asking you because nobody else has asked this question, is how will your project change based on whether you get the first prize, second prize, or third prize, if you get a prize, of course. Yeah?
All right, so that's a very hard question to answer, but I think from our previous calculations when we did the budget, we thought 1/3 of the budget would go to the infrastructure. But after having talks with I think the partners that we're thinking to work with, they thought the setups and all that, we might need probably solar charging panel, things that, okay, I'm not very conversant with the technicalities of it, but they were looking for equipment that could have what do you call this, batteries that can store in power to use when it's raining and all that. So we thought that might be very pricey, but we are still in discussions on what equipment would actually work with the budget that we have, because it's partly implementation research as it is. We want to pilot something, but at the same time we would want to carry out research. What do the communities think would work much better? Even if we are providing them with the solar powered kiosk, where would the women want it to be? Is it at the facility? Is it in the village at the chief's place? Is it, yeah, so, yeah. Thank you.
Okay. Anyone else? No? Great. Then let's do a round of applause, of course, for Nissily, but also for all 3 finalists. Thank you.